muscular impairment. And I think that for personal trainers, you can elevate your that's a way to elevate your thinking and be more effective and specific without having to have, you know, a doctorate or any of that. It just being a little bit more ordered in your thought process, but ultimately it gets back to anatomy. If you understand your anatomy and you know that the glute medius does this and this, then you can just overlay that into any of your exercise choices or interventions. Does that make sense? Mm-hmm. Okay, cool. Let's do that. Okay, so I'm sorry, should I have done this? All right, do we need to?
You're set up.
Do you want me?
I already think that. You only need one of them, whatever one.
I think I have it set. I might have it set where I have to have them. Is it working? Yep. Okay. I thought I had it set where, okay.
You want me to put the study on the projector?
Oh, God, if you can, that'd be awesome. Because it'd be good if we can just get visuals, because I can't remember all the, I can't remember all the ones that they went through. Okay, let me fix this.
My right side part's been feeling better, but now the left one's been bothering me.
Take off the auto lock, and then I'll pull up my muscle anatomy.
Alright, it's up there now. Cool. And then we can also put it on the...
All right. Okay.
I had to re-download it. It always wants to update. So I was messing around on it last night. It's pretty similar though.
Yeah, just have an app that you use.
Yeah.
Like whichever one.
That's the best.
I think I got this one. Like I think there was like a sale. Like I got it for $1. But that's the thing is just use something. Like, and I think like what happens sometimes like. When, like, school kind of ruins us in a lot of ways where, here, I'll just give you guys this so that you can talk about, you can use that, yeah. I think school kind of ruins us in a way because we're kind of taught, until you get to, like, the graduate where it's more complicated thought process, but, is you're taught to, like, you're supposed to, like, regurgitate the answer. And I think the higher level thinking of, you know, what Chris has been trying to, you know, facilitate with folks is to just, there's no, like, to think. Like, just, if you don't know the answer, just look it up. Right. Like, you're not expected to know everything. And so, if you've always got an anatomy app open, and anytime, and you're quizzing each other, or you're quizzing yourself, like, let's say, you know, you watch somebody do, like every time somebody's doing something and you quiz yourself, what are the muscles that are the primary movers? So, okay, I just did this. What's the main muscle that's acting?
Gastroc, Medius, and Soleus.
Okay, and so, but all right, let's be more specific. So it's Gastroc and Soleus. Why?
They shorten, causing me to.
Well, based on because it's moving what joint?
Ankle.
So ankle, what's that point called? So ankle plantar flexion. So we're going ankle into plantar flexion in technically a closed chain position. Now, what's the difference between, and so then that next, so ding, 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 you won. Then what's the next, Everybody did, because you all had it. But what's the next layer then of thinking would be, what's the difference between Gastroc and Soleus?
Gastroc's more superficial and Soleus is deep.
Okay, so how do they control different joints differently? So go ahead and this is where you want to look up your Gastroc. And so the question is, there's a difference between the joints that they cross. The Soleus crosses how many joints?
One.
Which joints? So so it is active whether your knee is bent or straight, correct? Because it doesn't cross the knee. And so then by elimination, the gastroc crosses which?
The knee.
Yeah, and the ankle. So if you want to bias the gastroc, what position would be the best for your knee?
This one.
Oh, actually, let's just grab something and work this out in our brains. Find something where you can be off the ground.
So something where the ankle would be.
Yeah, so climb up. We're kinesthetic learners. Let's just figure this out. Because this is another thought process that you're having, too, so if you're trying to work that out in your brain, so if you're up here and your knee is straight, where do you feel it? And so what else do we have? Let's find something else for you guys to be. Get up on something so you can. No, it needs to be something hard. Here we go. So stand up on there, hoofty, and have your knee straight and feel where you feel it.
Straight.
Okay? And now bend your knee. Correct? So if your knee is straight in a closed chain position like this, you're getting more gastroc. You're feeling it more proximal probably. It's probably going to be more up here. Yeah. And if your knee is bent, what you're noticing is you're inclining, you're going into more dorsiflexion, and that's more of a deeper. And if you have a lot of ankle dorsiflexion, it's tough to feel it in your gastroc, in your soleus. And then random factoid, the soleus is usually what's happening when people get shin sprints. It's usually a posterior musculature, but not the anterior. A lot of times people miss it. It could be anterior tib because of greater eccentric load from a higher heel counter, or that's a whole nother conversation, but yeah, so being specific, so what did we just go through that thought process? You saw somebody move, you triggered yourself to say, hey, which muscle is the primary mover? You were like gastroc soleus. Some people like to try the triceps serrae because they want to sound fancy. I think it's the strength and conditioning folks. They'll use that term, triceps serrae. I went to a really cool, triceps serrae. So it's basically the three muscles of the calf. That means it in Latin or something. So some circles use that term. In my experience, it's been the strength and conditioning folks. They say triceps serrae instead of gastroc soleus or calf muscles. But yeah, I went to this really cool symposium. It was Gray. What am I having? The FMS guy, Gary Gray, and then who's a physical therapist. And so we had the FMS guy, Gary Gray, and then we had Stuart McGill. It was really cool. And then it was talk about collaboration, and then it was sponsored by Craig Lieberson, which is a chiropractor who's really successful in the LA area. And then also we had Chris Powers, who's a physical therapist who's done a lot of research on patellofemoral kind of stuff. But yeah, it was really cool but they're all saying triceps serrae, and I'm like, what do you guys? Okay, anyhow. So that's just one of the things that went the way where you can be layering and moving, like learning throughout your day, because you're not. And it helps you be more engaged with your clients if you're really thinking about what they're doing. And if you're thinking about what they're doing and then that anatomy, then you can be a little bit more specific. Because I think there's ways people can be doing things that are a little bit harder. But if you're specific according to what you're focusing on. So then taking it another step, I'm just kind of talking clinical reasoning just to start off with. Okay, you just saw this. So the primary muscles that are creating that plantar flexion are the calf muscles, the gastroc and the soleus. But what other muscles are kicking in primarily or secondarily? Your foot muscles. Yeah. Your foot intrinsics. Yeah. It's just your foot muscles. Right? But what else does this require? If you're standing up on so your base of support is bigger, and now it's smaller. So then you can be looking at, so this is a balance issue as well. So making the base of support smaller, you're making it more complicated than if you're just standing. So that can be an easy way to make something harder, just by making the base of support smaller. So then you can kind of be looking, but then, so if somebody is if they're aligned properly, when we're just standing, I need to get the visual of that. When we're just standing, if you're standing upright, you're not using any muscle strength. You're just lined up like a stack of dominoes. When you come outside of the vertical is when your muscles have to kick in. So if you lean backwards, your quads are kicking in to pull your pelvis forward. If you're leaning forward, your hamstrings have to kick in to pull you backwards. And it's all happening mostly at the ankle, that ankle strategy. You can feel your calf muscles, your anterior tibs. And so just being aware and mindful of kind of what's happening, and just, you can be quizzing yourself on your anatomy like all day long. It's really cool. So that was just random as far as thinking. So let's just go through let's just review, let's say last week we talked about, or we've kind of touched on the being a little more specific about and fine tuning of exercise progression. So let's just review that. The most specific and easiest muscle contraction is just when the muscle increases in tone, but the joint doesn't move. And that's the isometric contraction. So that's the easiest one, where you just have them, and you guys do that a lot with the glute squeezes, the butt squeezes. That's just isometrically. And the advantage of an isometric contraction is it's not necessarily doing a lot of strengthening. That's more working on the neurological connection. Your brain is identifying the muscle, you're activating the muscle, and through that process, your brain there increases the linkage. So that actually will activate more muscle nerve fibers in whatever targeted muscle. And there's a term. Have you guys heard of the term Gluteal Amnesia?
Yeah.
This was years ago. It was like the fad. So basically, it's just the glutes are things go in fads. So this is gluteal amnesia. Is basically where people they don't really activate their glute muscles because they're sitting on them all day long. They're sitting on them, they're passive, they're not really doing, and then when they're not sitting on them all day in the office, they're really not doing anything that makes their glutes have to work. And so that's kind of a boutique term, a buzz term, gluteal amnesia, or core is kind of one of those terms too that's non-specific, but it sounds fancy. But that's actually a real thing. Like if you don't use a muscle, if you look at the brain, if you don't use a muscle, then your brain, the nerve impulses to it actually decrease. So anytime you start putting somebody on a strengthening program, or the first initial amount of strength, are you okay? What's going on?
Yeah, I'm rolling on my head. I'm okay though.
Okay.
Do you want me to stand?
No, I just want to know why are you,
My hips are just tight.
you're hurting?
It just makes me pay attention better. I'm looking for a real center.
Okay.
I'm good.
You should just hang out in pigeon for a little while. That's an intense stretch.
Yeah, that's okay.
Yeah, okay.
I
'Cause,
did red one, girl.
if you really want to get something done in the piriformis, because then you get your hip flexors and all that too. But okay. So, where was I?
Sleepy flexion.
Gluteal amnesia. Okay, so we start off with wherever. I'll circle back around, I'm sure. So with so the initial strength that you get from a person when they first start exercising is not hypertrophy of the muscle fibers. It's increased connection of the brain to that muscle and then an increased nerve input to it. And so that's where you start off with that isometric contraction just to get somebody aware of it, and you're increasing that brain-body connection. So isometric, no joint moving. So then that next activity, so first you have to, if you want to get somebody working a muscle better, first they need to be aware of that muscle and just be able to contract it. And so that's isometrics. And then next you want to move on to that next type of muscle contraction, which is where the muscle is shortening and it's moving the joint, and that's the concentric. And so that's where you're moving a joint and the muscle's getting shortened. And so you start off with just the muscle contracting, not affecting the joint, and an isometric so that you increase the awareness. And then you go to a concentric one joint contraction, and it depends on what's going on, but the easiest thing to do would be in a non-weight bearing setting where you don't have all the other stuff to go on. And so that's where we're going to kind of start here. That's where with the hip muscle, with the hip region, starting off with the glute squeezes, the progression would be starting off with those glute squeezes for the isometrics to get the awareness. And then that next progression would be doing the side lying, the clamshell type exercises. And so let's just look at the ones that are recommended here. Do you want to just kind of scroll down? I think this, if you scroll all the way down, that's where the photos are.
I've been emphasizing more pelvic mechanics lately, a little deeper than just squeeze your butt, because some people squeeze their butt and then their pelvis goes whichever way, or usually just forwards, but just kind of more awareness of where your hips are facing.
Yeah, and so the thing is like, it's important to not, you teach people something, but then you need to get away from it. Like if you're using like squeeze your butt as a cue to be aware of it, as soon as they're using it and they're aware of it, then you stop with those cues, because you can't have people walking around. I mean, they should, people, the ultimate goal is for people to be able to move without having to think about it. And that's so as soon as you're noticing that they're having some control over here, and you're noticing like something that's asymptomatic, then you're taking it to the next level and addressing that particular person. So that's good. Yeah, but people, it shouldn't be that hard to just, people should be able to just stand without having to take up 90% of their frontal cortex.
Where do you want me to go?
Scroll down to the photos of the clamshell, if you keep scrolling, it's like towards the bottom. Or let's see the graph.
I like the part where it talks about the hip angle of the clamshell.
Yeah, and so we're just looking, just so you guys know, if you haven't scrolled through this, you don't have to read the whole thing, just scroll through and look at the pictures. So this just shows that the percentage of contraction is what's happening with those. So that's just a nice angle. All right, so come on down. Were there any of those that you were surprised by?
Oh, the transverse lunge, how that was far more, or not far more, but more than the two normal, or the other forwards, backwards lunges. Is transverse just referring to just like diagonal?
I think it's the curtsy lunge, yeah.
Okay, yeah, that's what I thought.
I mean, it makes complete sense when you think about it, but we forget about, I mean, this is one of my favorite lunges, but it's one of those things that we forget about, because if you don't use it.
Maybe we just go everything here.
Yeah, and so, yeah, all right. Let's see. I think for me, yeah, you stay in the one plane, and then that's another level. You stay in the same plane, and then you add a different plane, and then multiple joints and all that. So I think one of the things, too, is like, I really just think the overuse of the bridge, which is what I love about this study, is it just shows the bridge is really doing nothing for your glutes. It's all hamstring. And then even if you guard, there's just not a lot of, the bridge is just, there's just so many other things that you can be doing that are more functional.
It's one of those moves where people can engage different muscles to still get the job done. Like,
absolutely.
Use more like hip flexors rather than core and things like that.
Yeah, and you really have to be aware of how to position a person. If they don't have their heels close to their glutes, it's all going to be hamstring. And so you're really not getting any glutes because the hamstrings just they're doing everything. So you have to put the hamstring in a passively insufficient position. Is that a term that you guys know of? So if it's too shortened, if a muscle is too short or if it's all the way short or all the way long, it can't generate very much strength. So that's a way to bias a muscle out of an activity. So if you wanted to do a bridge and you wanted to take the hamstring out of it, you shorten the hamstring by having their heels way up here. But from a functional perspective, and from me as a physical therapist, the chance of injuring somebody is pretty high in a bridge. Because if anyone has had anything going on with their back, because when you come into a bridge, you're just compressing the lumbar spine, you're compressing the cervical spine, you're just creating, there's no movement pattern that, except for maybe in activities of nightly living, where that particular movement pattern is functional.
Activities of nightly living.
Yes.
Okay. Yeah, okay, yeah.
Right over my head.
Yep. That's actually, it's fun.
But isn't that good to, like, everyone spends all day sitting and you're putting them to the opposite of that? Like,
Not really, because there's so many better ways to do it, because you're not going into any hip extension.
Yeah, it's not the opposite because your knees are still bent.
Yeah, your knees are bent, your hips are still at neutral. Now you're crushing their cervical spine because they're doing all this weirdness.
One of the reasons when I do assessments, I don't usually use bridges.
Yeah, I'm just not a fan of the bridge, and it's just.
I will use it to keep some hamstring fueling, and you can, certain people, if they don't have a glute stuff, or low back stuff, you can have them engage their glutes, I've noticed, but I just find there's more effective ways, like she's saying.
But yeah, you just look here, like the bridge doesn't engage the glutes hardly at all, and like you were saying, Sydney, people just really find unique and creative ways to screw it up. There's just so many other ways to do it. Like, if you actually want to engage the glutes, in this here, we're kind of jumping ahead, the best way to do it, and if you think about it, about what we were kind of dovetail back to what we were just talking about, was isolating a muscle group. If you know your anatomy, let's go to the glutes, the glute max. Show us the glute max. So the glute max runs from where to where? Just kind of point. From your pelvis to your femur. Let's just go that way. Okay, so if you know, and the muscle fibers run in which direction? Go ahead and show us that. Are they in a straight, or are they slightly off to the side here? So what does that tell us?
Line of pull is also.
So it's slightly off. So that's going to bring your hip into extension and a little bit of in external rotation and abduction. That's biasing the glute max, if you really want it. But hip extension is the primary movement of the glute max. That's the main thing to really be aware of. Glute max, hip extension. So, with understanding that hip extension, so of the hip, making it extend. So logic then would dictate, this is why the bridge doesn't make any sense to me. If you want to target the glutes, why don't you have your hip go into full extension? If you're lying down on your back and your feet are on the floor and your hamstrings are short, it takes a significant amount of strength to be able to come into being in a straight position here. But getting past, this is a neutral hip. Hip extension is way up here. That's really hard to get. It takes strength. And then you're crushing your neck and all that. So how about if we just be a little bit more, let's make a little more sense here. Plus, when you're lying down and the whole floor is helping you, you're taking out the activeness, the use of the core and your back muscles and all that. So it's not super functional. So what is this? Hip extension. What else were you also, and is this is this a functional movement? Maybe not on all fours, but when you're walking, what are you doing when you're walking? It's a functional movement pattern. And that's where the manual muscle testing that we know from physical therapy is like that's if you want to isolate just that muscle group, you're going to have them go into just hip extension. So I mean this, you can do a lot with this, which is you got just your hip extension, you can add resistance, you can have people do things that are, you can go through a bigger range of motion, but if you want to actually target the glutes, you need to bring them into hip extension rather than go to hip neutral like in a bridge. So that's what I love about, that's probably the biggest thing that I loved about this, was to show people who were on the bridge kick that they weren't accomplishing what they thought they were accomplishing. So, all right, let's go down to, let's see, oh, and the side plank is probably the one, too, that causes the greatest glute med recruitment. All right, okay, so scroll down, let's go down to the photos. I keep getting off topic, but not really. Let's go through the concentric single joint exercises, which are all the clams. And what I love about these clams is it shows all the different ones. Like you were saying, was it you one that was talking about the different angles?
Yeah.
And so being aware of, because here the glute is where? Is it short or long?
Short.
Yeah, because it's the hip extension. And so changing where you are changes the amount of, and whether or not your heel is connected or supported, whether or not you're coming with your heel towards the ceiling or the heel away from the ceiling. Those are different activations.
Yeah, but changing the angle of where your knee is, or the hip angle, but changing where your knee is affects also those deep, like the pelvic floor muscles too when you're going to do it. Or yeah.
Right, and so that's so let's just kind of go through what these are, because that's actually more of a hip flexor activity right then that you're doing. That's hip flexors, because your hip is flexed and you're lifting, and so that if you were going to palpate, we're getting mostly. So let's kind of go through here and talk about, Juan, do you want to be I guess we could, let's just put you here, and we'll just go through them all so that we'll go through the cueing and the anatomy of these. Are we okay with lay with your head that way. Maybe flip facing them so we can see. Okay. Okay, so the top exercise there is just your basic clamshell that everyone is familiar with, or everyone should be familiar with, and if you're not, oh well, you will become familiar. So the main thing is we got the hips at about 45 degrees, mostly the bottom hips so that they're comfortable, and then making sure that they're feeling like they're not going to fall down. For glute medius, it's really important. What's the most common compensation is the overuse of the hip flexors, and so that's what a lot of people really don't pay attention to. And so if you have the pelvis perfectly vertical, like this, a lot of times they'll be here because they're not comfortable. Make sure that they're fully vertical with their pelvis, supported at the lower leg, comfortable here, and maybe if they need a pillow or something, like so make sure that the person's comfortable, because people don't always tell you that they're, oh my God, I'm in pain. And so the first one is the heels are together, and all they're doing is they're just lifting their knee towards the ceiling like they're opening a book. And do you guys want to practice it? Well, let's all do this together so that you get the cues down, because and the palpation. Here, you and Mike and Sydney. Chris, do you want to work with Hannah?
Between setting that up.
Oh, okay, perfect.
String people and our followers.
Oh, okay. So you're working. All right, Mike, I'll trust you to work between the two of them. Or Hannah, do you want to?
I can do whatever.
Yeah, I want you to be able to get your hands on so you're feeling. So the key also, if you're going to be doing anything with, if you're targeting a particular muscle, you want to palpate that muscle for two reasons. For one, for you, because it's giving you information about whether or not the target muscle is contracting. Because you know what? You might be surprised by what Sydney was saying. Sometimes people compensate in ways that you never would have expected. Like I had this happen with a patient not that long ago. She'd had some shoulder pain, that it's actually long-standing shoulder pain. It's been almost a year we've been working, and she's been improving. But I had her laying down, and I was working on her shoulder, and I had her lift her arm, and I realized, because I had my hand on her, that when she lifted her arm, she used her bicep. I know, I love that. So the bicep, it actually, your bicep actually assists. It's not just elbow flexion, that's its primary movement, but that end range shoulder flexion, it assists. The long head of the bicep, it crosses that joint, so it's only end range. But I had her do this, and she actually contracted her bicep. And if I hadn't had my hand on her, because I just assumed she was lifting with all the other shoulder muscles she should be lifting with, not the bicep. And that revealed a compensating motor pattern that I wouldn't have noticed if I hadn't had my hand on her. So for one, if you're palpating, you can feel if it's the muscle that's targeted. Plus now, what are we doing? We're getting better at our anatomy. Okay, glute medius is right here. But then you're also educating that client as to what muscle group you want them to be contracting, because they need to know what's happening, because that's what you're starting when you're starting with the glute squeezes. You're trying to get them educated as to and aware of their body. Like that's a big part of the best day method, is educating the clients to be able to live their best life through knowing what is happening. So if you say, and then you get them, first of all, you start off, okay, this is the muscle group I want you to feel the contraction in. Keep your heels together. So go ahead and just practice. Do this at the same time as I'm doing it, Hannah or Mike. So you got your fingers here. You've made sure that they're comfortable. Their pelvis is perfectly vertical. They feel like they're not going to roll over. You palpate that muscle group. Now just go ahead and keep your heels together, and practicing your script is important too. If you like fumble through and you say all the words and over-explain like I'm doing, people can actually lose confidence and maybe fall asleep. So keep your heels together, and notice I'm giving tactile cues, because people don't always, I can't tell you how many times, and I'm sure you've had it happen, where you say contract your quad and then they go and contract their head. Like people don't have that brain-body awareness. So the tactile cues help, they help cue the patient as to what you're expecting, help them have the body awareness, but it also reduces the chance for embarrassment. Because if they don't really remember what a quad is, and you say something and you assume that they know it, and then they don't, and they don't do it right, like some people, that can be really embarrassing. So, you don't want to make people feel stupid. Like they came in here to help you, for help. So that's where the tactile cueing, it just really benefits everyone. And so, okay, this is the muscle group I would like for you should feel it in this muscle group. Keep your heels together. Now go ahead and just lift your knee up towards the ceiling. Oh, great. And then lower it down nice and slow. Why is it important to lower the leg down slowly? What does that do? What's our third muscle contract? Yeah, exactly. So the muscle is contracting. It's a concentric. And go ahead and put your hand on the knee so that you're learning how to just remembering. So, and you'll notice too, this is fine tuning. If you notice your tactile feedback, you need to be specific with it. If you want them to, if you hold the knee like this, you're touching both sides, and the patient won't know which way you actually want them to move. You'll be saying so if you want them to bring their knee up towards the ceiling, be specific, bring your knee up like this, and then if you want them to bring it back down towards the ground. And so just being really mindful of the cues that you're giving someone, because you can easily really confuse someone.
Yeah.
And so now we got a nice eccentric. Whoa, lower that down. And then if you wanted to, you could provide a little bit of resistance when they're coming up. But okay, so that's the first one. So we got to the first clamshell. So this is your traditional clamshell. And so you cue them to understand that it's this muscle. So let's see, if we look at here, the next one is we've got some distal supports by having the heels together so that it makes it easier. And we're targeting just that glute medius, which is doing which direction is this, the hip moving?
Out or external?
External rotation, and away from midline is abduction. So this is just pure glute med, nice and supported, really concentrated. So, okay, they can do this one. They're aware of it. They have enough strength. Now, the next thing to do is to add a little bit more, make it a little harder, but not just taking, we've got lots of training wheels going on here by keeping the heels together and having it be super specific. The next one is you keep the knees together and you bring the heel up towards the ceiling. Feel how that's different. So all you're doing is internally rotating the femur. So bring your heel towards the ceiling, keep your knees together. And Mike, that's going to be up here, like right, let's see, like between the PSIS and the iliac crest. There you go. Side butt. If you turn your hand so that you're in line with because then you won't accidentally be here and get surface. So now, do you feel how that's different, Juan?
Oh, yeah.
Yeah, right? It's harder. Go ahead and try it, Hannah. Just try the exercise yourself.
Oh, I tried it.
Okay. Well, I just want to see if you're doing it the right way. There you go. And so keep your knees together, and then you're lifting just. Yep. And what's interesting is towards the end, she goes into a lot more hip. She brings in the hip flexors.
Yeah.
Yeah. So you got to be mindful of the form.
Yeah.
So what you'll see is if those knees aren't properly stacked, when she was getting to about right here, watch her hip. If you just watch, when she gets to about here, now we get hip flexors.
Yeah.
So that's where really being mindful of the form. So if you've got your fingers right there, being careful that you don't poke her in the butt, make it be weird. And then this is where with her it's pretty clear, you can just watch. So right there is where she wants to start coming forward.
Yeah.
So then that's where you have some nice control this way, and you can see it, and there you go. And if you teach them that, and being really mindful of how, like those first couple of repetitions, if you're super specific about what you teach them, then you don't have to undo the improper movement pattern. So let's say you're not paying attention, and you let her do 10 or 15 or 20 repetitions when she's doing mostly the hip flexor, and you didn't educate her that it's this muscle group, she should be feeling it, then you taught her how to do it wrong. And now you have to undo it. So that's kind of fun, right? Okay, so we got the heels together. Wait, we're not done. Stay where you are. Oh, okay. Oh, Hannah, do you want to be the patient or the client? Just switch amongst yourselves. Okay. So first we started off with the heels together, and then we moved to the knees together, and then that next, and so if you're looking at our photos here, it's a little weird to see. So the next one is the knee is apart, and you're bringing the heel towards the ceiling. And where are we at as far as our hip angle? We're still at that 45 degrees because is it easier? If you're here, it's going to be a little easier. Okay? So now so do you like that progression? We heels together, knee towards the ceiling, knee together, heel towards the ceiling, and then it makes a little bit of sense now. It's the same. If you bring the heel towards the ceiling, your knees are supposed to be together, and you're rotating just your heel towards the ceiling. Sorry. Wait, nope, sorry, you're right. So, but your femur is staying in the same spot, and you're just rotating your heel towards the ceiling. And so, Hannah, or Sydney, go ahead and practice this move. Get all up in there. So come on here. So wait, hang on. Do you see how I'm supporting at the knee?
Yeah.
There you go. And then look how you can catch her with, you can control with the, see how you can control with that forearm?
Yeah.
I've got her, my forearm is a little longer than yours, but see how you can have control over the whole leg?
Yeah.
And so now you can teach her, just by a little bit of a shoulder shrug, bring your heel towards the ceiling, and you can find out whether or not, because what other muscles are easy to compensate with? Yeah, the hip flexors. Yep, and you can also be doing the, you can get your adductors in there. You can use. Yep, and so, so it's just a straight rotation, Hannah. So we're getting the hip into neutral. So the femur is parallel to the ground, and then the heel is just coming towards the ceiling. That's it. It's just that straight rotation.
Yeah.
And see how you can control that. I just trapped.
She's kind of just doing it on her own.
I know, but the goal is to be able to.
Yeah.
So flip your hand so that you've got her. There you go. Yeah, that's.
Okay.
See now you trap that hand foot. There you go. See how? But it's rotation. So there you go. We're just rotating. There you go. And then so that's how you first teach them, by having your hands on them a little bit more, and then now you cue them. Okay, keep your leg there. Just bring your heel towards the ceiling. Bring your heel towards the ceiling. Okay, take your rest. That's hard, right? Okay. So that was with that 45. That was with that about 45 of hip flexion. And anytime that hip is flexed, we need to make sure you're not getting the hip flexors. And then to make it a little bit harder.
There's more?
Yes. Do you want to flip? No, you're good. We'll do. Now you bring the hip into extension. It's the same thing. You bring the hip into extension, and then you're rotating. So now the hip is extended, and you're going to rotate towards the ceiling. There you go. So that's the progression of just the concentric one joint glute medius. So with any muscle group, you use the same thought process for progression. Isometric, no joint movement, concentric, one joint movement, and then with the hip, because what kind of a joint is the hip? How many degrees of freedom does it have? Yeah, it's got the 3 degrees of freedom, so we moved into the rotational aspects of it to be contracting it. You can't really do that if you wanted to do some quad strengthening, you wouldn't be adding rotation. So that's a whole other conversation. Okay, so do you see that the framework of progression?
So we went from isometric no joint movement to concentric one joint movement?
Actually too with this, so concentric one joint, one plane of movement, concentric multiplanar movement, if it's a 3 degree of freedom. So,
still one joint, one.
Yep, one joint, one movement. So,
One joint, one plane movement, and then one joint, multiple planes of movement?
correct. If it's a joint that does multiple planes. So, which plane is this?
Frontal, right?
Frontal, because it cuts you into front and back. And then which plane of movement is this? Sagittal. And then what's the one that goes through you and it creates rotation? So transverse is rotation. Sagittal is typically flexion and extension. And then frontal is AB and adduction. So those are things to consider as well. Like what, because so you can make an exercise harder by changing one of those variables, right? Okay, so now let's add a joint. Keep going. There should be more like the, all right. So now, I think the hip hike, are underutilized.
I was trying these the other day and I realized how difficult it was.
So I'm going to tell you that I've noticed in my a long time use, there's a significant gender difference. So let's take these so everyone can get on them. So first, with a patient, actually it's probably easier to train them when they're hanging off of something. But what I'll do is, okay, so we went isometric, no movement, concentric, one joint, one plane, concentric, one joint, multiple planes, and that was all non-weight bearing. Now we're adding weight bearing, but we changed a variable, but now we're going back to just the concentric one joint, one plane. So if you're, go ahead and guys, let's I'll always test this. If you have a person put their hands on their iliac crests, then they can tell whether they're moving, and then have them straighten the leg you want them to move, bring their toes up, because that makes the whole leg stronger and engaged, and it actually shortens it.
So do you want them to lock their knee out for this?
I don't really like the term lock the knee, because let's talk about this. So lock, technically the term lock the knee or lock a joint implies that the stability is only from the bones. And so I think what people mean when they use the term lock out as a bad thing, because a lot of times I'll hear people say, well, don't lock out your knees. What they're intending is don't hang on the ligaments. Okay, so here's this. My knee is locked out, and it's hanging on the ligaments and the bony anatomy right now. Can you see that the muscles are not contracted and the joint is not protected? And so I think that's what people mean when they say don't lock it out. But so this is a passive, the joint is being passively controlled just by the bony anatomy and the ligaments. So this, if you're hanging out here and you're just locked out and passively all day long, that puts a lot of shearing forces through those joints and can be problematic. Versus an active, so this is technically what? Knee extension. So this is a passive knee extension. It's going into what is a apparent hyperextension. Now, if you have somebody actively controlling their knee, it's straight, but it's not locked out. It's fully engaged, and that knee joint is not at risk for injury. So being aware of that distinction is really helpful, because this is healthy and exactly what it, but depending on the range of motion a person may have, if they don't have this extra extension available, they could be locked out, but it looks like it's controlled. So this is safe and healthy and highly encouraged because of the way, and this off topic a little bit, but the way that the knee joint works is, and I love how the hand anatomy is perfect, until almost straight, the knee is unstable and the bones are not congruent. So if you put your two middle knuckles together, you see how this is the femoral condyles. The last 5 degrees of extension, the knee locks, and that's where that term lock. The knee locks into extension. Do you see how your knuckles are coming? Now this is a good, strong, stable knee being held together by the bony anatomy, and the chance for injury is limited. And so that's where people who are good at what they're doing is worry about having knee extension, because this is a safe knee. Does that make sense? So this is called the screw home mechanism. That's where you need to have full range of motion to be able to get into full extension. And if the muscles are holding the bones together actively, you're not going to get any sliding or shearing forces. See you later, Hannah. That are going to damage, that could potentially injure that joint. So
in a little historical thing, one of the things we use to teach new people that we have in an assessment is when I have them stand there, usually when we're talking to them, they're going to be locked out or it's fully extended passively.
Yeah.
So we take that as a time to teach them about how the quadriceps and the hamstrings and all the big muscles around the knee are not doing anything right now.
Active, yeah.
So the subconscious brain has put you in a position where it's an efficient way to save calories.
Yep. And it's based on your alignment.
Mm-hmm.
Yeah.
So that's really interesting to hear you put it that way, and that could be something we explain, that it's okay to lock knees out or actively extend knees, but we need to differentiate active from passive extension.
Yeah, so if you're trying to be strong stable
but again, we're simplifying it for the client. It's like, okay, locked out, okay, that makes sense. It doesn't, we all know the difference in the anatomy now, but to a new client, we can't go through that whole lock home or screw home mechanism with them and
I do that.
Intrinsic knee mechanics, but telling them locked out with no muscles working versus maybe we can just switch the verbiage to extended knee with the muscles being more active.
It's like just have a power stance and a passive stance.
Power stance and passive, that goes with our power diamond, right?
Yeah, and so I think what you're trying, actually, you bring up a really good point. Because you guys talk a lot about postural alignment, and so somebody who can achieve passive straightening of the knees in a standing position, that means they are properly aligned. That's a good thing to make them be aware of. If they're passive, if you're perfectly lined up from a postural perspective, your body, your brain defaults to being efficient, and you're kind of just wobbling here. You're stacked up, dominoes. So if you're able to achieve passive extension of the knees in standing, that means you're in proper alignment. So that can be a good thing.
So if your brain goes back to that efficient pattern of being completely good, neutral anatomical alignment, that means that all your muscles, when they're in their relaxed state, are still maintaining neutral.
And it's physics. If you're aligned properly, if you're aligned properly, it's physics that's holding you upright, not muscle contraction. And so the muscles need to contract to provide stability for mobility. So if you're going to do something, then you need to contract everything and be powerful. But if you guys are noticing people are passively here's another tangent. If somebody is standing so that their joints are locked out passively, that usually means that they're seeking more proprioceptive feedback from that joint. Okay? So here, I know this is super nerdy, but we're good company. Ligaments, and this is one of the things that I love learning in PT school. A ligament connects a bone to a bone, right? That's like, did you hear my Minnesota accent? A bone. Minnesota just came through. A ligament connects a bone to a bone. It's its primary goal. But its secondary job is to provide proprioceptive feedback to your brain as to where that joint is in space. So the short version of that is your ligaments hold your bones together, but it also tells your brain where that joint is. So if somebody is doing one of two things when they're just standing, or one of two things, if they're bending a joint when they're standing, or if they're having it be more extended passively, that can be that joint seeking more feedback, because you're getting more feedback if you're doing this or if you're doing that. So that can be a proprioceptive strategy that the person is using. Because you've probably seen people, and this is where understanding that proprioceptive part is, like, have you ever had somebody do like a heel raise, and they bend their knee, and then they come up on their toe? They'll do this.
That doesn't happen as much as locking out, I noticed.
Yeah, but I see what you mean in terms of they shift their weight forward.
And so understanding proprioception should cue you to investigate, well, I would investigate, to just be aware of they might be bending their knee because they're unbalanced and they're seeking more feedback. It's not necessarily a strength issue.
Or some people just try to lock it, so to say, and then just do it from there.
But that's good. You want the muscles to be fully engaged when they're coming up and controlling that joint. That's actually a good thing. Are you talking about the passive locking? That's really hard to do, to come on to passively.
Yeah, I guess it would be.
Is your quad engaged when you?
I guess it's not to. I'm trying to do it.
Yeah, that'd be hard.
It's really tough to do. But I'm just saying, like, sometimes they'll see somebody do this subtle bending of the knee, and they'll think it's a strength issue. But really, more often than not, it's a proprioceptive issue. That person is having, because when they come up on your toe, you're reducing the base of support. So this is less stable, being on the ball of your foot, than being on your full foot. So if you bend your knee a little bit, now you're getting more feedback through both your knee and your ankle joints from proprioception.
So it would be healthy to do 3 kinds of toe raises in terms of bent, extended,
No.
hyperextended?
Nope.
Okay.
Nope.
So,
It's just if somebody is using that proprioceptive strategy, that just says they're not very well balanced. So if somebody is standing out here with no support and they're doing their little this, and just you didn't give them any cues, you might be like, let's give her a little more balance and see if that goes away. So then you'd say, okay, hold on. And then if they go ahead and normalize that and they don't bend their knee, that would tell you that it was a balance thing. This is a lot. But this is a lot. I mean, I'm just planting some seeds, and we'll talk more about this later. But if you add the balance perspective, give them more balance, and the reason they were bending their knee was from a proprioception because they were unbalanced, and now that knee flexion goes away, then you know that was a balance thing that was happening. But if they continue this, it might be a habit too, and then if you cue them, you've given them more balance, and now you cue them, hey, keep your knee straight, and they're able to succeed. It was probably a combination of both, a little bit of proprioception. And so that's just kind of your random, not really random, but just being mindful of if they're bending their knee and there's that, just be mindful of the proprioceptive use, the unconscious strategies that the body uses to know where it is.
I guess my only question is, where should the knee be for a toe raise then?
Straight, fully straight and active.
Okay, cool.
It should be actively straight. So I always cue, okay, if I'm assessing someone, I don't give them any cues because I want to see how they naturally come into a toe raise or heel raise. But if I'm going to be having somebody do a heel raise as an exercise, you cue to activate that entire leg. Tighten everything up.
I've been cueing soft.
Nope, no. No, because you're cueing them now to be unbalanced.
And that's something that I've gone over with y'all, and that's one of the reasons we're having this time to kind of oversee some of the stuff we've been doing, so we can all kind of go more forward with evidence-based stuff, and that's where her specialty is. It's worked for me in training y'all in the past, but I just want to bring it up to the next level.
Right.
Yeah.
So now if we're trying to teach people how to recruit more muscles, that's a way we can maybe have them feel certain things, and it's definitely something that I've taught y'all, and probably we just need to modify it.
Yeah. So, okay, yeah. So, so just being aware of what you're doing is, I think, really the main focus here. So having your legs completely contracted and super strong when you go into the heel raise is the first level of performing that movement pattern. It's more complicated to add the softening of the knees. It could be more complicated depending on that patient, because now the leg isn't as rigid, so now you have movement in the knees and you have movement in the ankles, so it can be more challenging from a proprioceptive perspective, but at the end of the day, from a functional movement pattern, more often than not, people need to be engaging. So just know if you're asking them to be soft in their knees, have a reason, and have a reason that's specific to the patient. So that would be something to do later rather than earlier. But I think you're probably using it as an assessment a little bit without really realizing it. I think that's what you're doing. You're doing the soft knees because you're getting a lot more information. Because if you straighten your knees, get your legs super, super tight, bring your feet together because now you're challenging the balance. Everything's super tight. Okay, compare that with bending your knees a little bit. Okay, here, just watch me. See the stark difference. Super tight, really engaged. Ramrod straight, look at my ankles. Everything is super stable. Do you see anything in my pelvis where everything super stable? If I bend my knees a little bit, now watch the joints especially. Ankles are moving. We've got all this. When the knees bend, you have all this motion available.
But doesn't that strengthen the ankle?
Well, strengthen is a really vague term. It depends on what you're trying to do. If you're trying to create a controlled movement pattern, this is specific to the muscle groups that are controlling the ankle specifically. If your leg is straight and your knee is straight, the only joint that's moving is the ankle. So you're getting those foot intrinsics and the Gastroc Soleus complex only, specifically. So you are strengthening specifically the ankle when you're targeting just the ankle by having all the other joints stable by muscle contraction. If you bend the knees, now you introduce all this dynamic movement, and you could be doing, it depends on the person, you could be training them to move improperly, because now they might be doing some weird stuff up here, and so there's better ways to strengthen the ankle dynamically, because basically when you have the knees bent and you're having them come up on their toes, you're adding a dynamic circumstance. Yeah. So now the ankle is in a dynamic, look, we got all these other joints. So there are better ways to strengthen the ankle without training an improper movement pattern. Does that help?
Yeah, that makes sense. But another question. So straight legs, good thing, not a bad thing. But what if when they straighten them, they go out or go in?
Well, if that's how they're...
Keeping them straight?
Well, it depends on how they're built.
Okay.
If they have if the alignment of their bones is into the genuvarum, which is they're bow-legged, if that's how they're built, then that's what, and muscles are engaged, then that's how you want them to be performing the movement.
I'm thinking more of the people that their knees are like when they go, no, they look straight when they're bent, but then when they lock them, whatever the right way to say it is, they go either in or out. So their straight isn't actually aligned.
So then you look up here.
Okay.
That's a really good point. So this is where being aware of how the different joints affect each other. And so, you'll hear me say this a lot, the symptomatic tissue is the victim, not the perpetrator. So if somebody has an injury, and you'll see people who have less training, they'll start pushing and prodding and poking on that injured tissue, when really it's the weakest link of the chain. So the most common, example would be somebody's got pain in their knee right here, and so you're doing massaging and gua sha and all this shit here, but they're not paying any attention to why it's happening, and it has to do with, because it's getting broke down, because it's the victim of uneven stress. And so I would encourage you, especially with your anatomy, the more you pay attention to anatomy, the more you'll realize how different muscle groups affect the ones in that chain. So the PT term, of course I have to rename everything. So when I was in PTA school, we said if you were looking at somebody's joints, you would clear the WUM above and below. And so if somebody had knee pain, you'd also look at their hip and their ankle to make sure that there wasn't something going on with those joints as well. Back in like 2007 or something, somebody used the term regional interdependence, which I think is a really good term. Regional interdependence, Rob Wayner, he's one of my heroes in the PT world. And regional interdependence, that's probably a term to start integrating, Chris. And that's just an awareness that the body is connected. So when you're looking at somebody's knees, you're making the novice mistake of only looking at the knees. Because the knee is what type of a joint? A hinge joint works in what plane?
Sagittal.
Flexion and extension is sagittal, right? So a knee can't rotate. If there's any rotation happening in a hinge joint, it's because of the joints adjacent to it. So that's where you use your regional interdependence knowledge and your bony anatomy. If you say, well, that's weird, the knee is a hinge joint, it technically can't rotate, but I'm seeing rotation of the femurs. Let's see. Let's look above and below and see where that rotation is being introduced. More often than not, it's the hip, glute med in particular, because it controls that femoral, and here's another term that Chris Powers did a ton of research back in the early 2000s, especially on patellofemoral pain, where the femur rotates underneath the patella. Before that they always talked about the patella being in the wrong position, but really it's just, the patella is not, it's a victim. It's just caught in your quad. It can't actively do anything. And so if you internally rotate and adduct the femur, if you just go knock-kneed, that's technically pronation, femoral pronation, which is a term that Chris Powers will use, and just being aware of. And so that's what you're seeing. When you look at somebody and you tell them to straighten their knees, and it looks like they're going bowed, or that what you're noticing is movement that's coming from the hip. So just think regional interdependence when you see something, and put on your Sherlock Holmes hat and your understanding of anatomy, and you can look at that person as a whole. Does that help?
Yeah. It's like I can realize it and pick up on these things, but then I don't always know how to cue it or what to cue, and specifically getting them to do it, because it is something that's complex, and explaining it to the average person to try to get them to do something that's specific can be difficult. Yeah, and that's where it's really important. If you understand your anatomy and what the muscles are doing, if you know that the glute medius puts the hip into hip extension, it's really easy to cue hip extension. Yeah. And you can just use it in a patient word. Just say, have your hip go like this. Mm-hmm. Or you could teach them that means extension. You know what I mean? So if that's where knowing your anatomy allows you to say things more simply, because when you're learning, you don't need to be, specific in your origins, insertions, and actions. Like the actions you can be simply, but you don't have to be spouting off the specific details. But if you understand the general movement pattern that each muscle group does, then you can explain it to the patient a lot easier, because you're not having to decode it in your brain. Okay. Does that make sense? Yeah. If you're like flexion, extension, abduction, adduction, you can change those terms to something a patient can understand. And so that's where having that impairment-based thought process
and being specific, a little more specific as to what you're doing, it makes it a lot easier. It makes it harder because you actually have to do some studying and really get your anatomy down. But once you get your anatomy and your basic understanding of the progression of things down, then you just apply it all to everything else. So everything that because what we're doing right now today is going through the strengthening progression for the hip region, but the same thought process and the same framework you apply to any other part of the body. We're just going to laboratize over this. I don't know. I think I just made that word up. We're just beating the dead horse. We're just going to go through this really specifically, because for one, hip and knee and ankle stuff are a big reason why people come in. But if you really get this framework, thought process down, then you'll be able to easily apply it to more complicated regions. Like if we were, like for instance, the shoulder complex is super complicated, and if we started with that, your brains would be exploding, and we'd be here for 10 days. Okay, so here's what I've noticed anecdotally in the clinic. Men have a hard time controlling their pelvis, not in the sagittal plane, because functionally this is something men do easily. Activities of nightly living also. But moving the pelvis in the frontal plane is not something like men do necessarily. Yeah. And I found it really interesting that when I teach somebody, I don't know, okay, you guys are too young for this, but do you remember or have you seen the TV character or the cartoon character Betty Boop?
Yep. Yeah.
Okay, boop, 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 boop. And so I use that boop, 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 and so training somebody that's what this is. This is the hip hike, and it uses the glute medius, and it also helps you remember how that glute medius controls the horizontal position of the pelvis, which also controls the vertical position of the femur. So if your pelvis drops, what happens to my femur? Femoral pronation. So, really being mindful of the pelvis, and so that's where that next step now, we were non-weight bearing, concentric contraction of the glute medius, one joint, right? Now we're weight bearing, concentric, but it's still one joint. So I'll usually just show somebody just in standing and see if they can just straighten one leg and lift it off the ground. Very often, this is extremely difficult. And see how Chris is wanting to come into abduction? That's really common because that shortens if you bring the leg out, and so just straight women, and like we walk in heels, because like in heels you have to take, okay, here's another nerdy little side. And you can wear heels because you're short. You're more efficiently built. Like I'm the wrong height for wearing heels. But women who know how to walk in heels, so when you're up on your toes and you're on high heels, how much movement is available in your ankles? Nada. It's been taken away by locking your foot in that windlass mechanism and all that. So, but that rotation needs to happen somewhere, right? So women who know how to walk in heels, that rotation that normally happens at the ankles when you're walking, because when you're walking your ankles are rotating. Women who are trained and properly walk in heels, they wiggle, that movement comes through in their hips. That's just your random. And so that's just my random, my anecdotal theory, like somehow the way that women move, we can do this without any prompting. So this is glute medius, concentric against gravity. So this is still just your glute medius, but what else is actually happening here too? Yeah. And then what about this? Which leg is going to get tire out first?
The one you're standing on?
Absolutely. Unless they're super weak in their glute med. So now come up.
Wait, this is for glute med left, right?
Yeah.
Okay. Concentric, because you're concentrically pulling the pelvis, the iliac crest towards the femoral head.
Right. Yes, so it's the opposite side. But the leg that you're, the leg that you're standing on is really the one that's going to fatigue first, a lot of times. So now go ahead and try that on the step. And that can make it, and you need to no, it's just hip. We're just trying to move, you're trying to just do this. So bring your dorsiflexion. So if you bring your leg into dorsiflexion, your ankle into dorsiflexion, that activates the leg and shortens it and allows you to, there you go, perfect. So the goal is just that glute medius. And so when you're off this, the step can be a way to trigger someone to be able to do it, but can be also a way to make it harder than just simply standing. More often than not, I'll have them do this as a trigger for how to do it, because a lot of times if they can't, because if you straighten your leg, dorsiflex your ankle, and that shortens your leg. But if somebody can't do that, then I'll put them on here just so that they can learn how to do that. But you have to dorsiflex your ankle, because that shortens the leg and tightens everything up. There you go. That's perfect. And now you have more range of motion, so it's harder.
Pre-stretching that muscle, or elongating it.
We're just trying to get this leg to feel even with the others.
Right? So now we're still one joint, concentric contraction. And we can scroll down to the next one.
Yeah, I was, with Dave actually, I was working on like pelvic mechanics with him, and I was doing glute med where we were here, and then I had him relax and then try to lift this one up closer to the wall by squeezing this one.
Right.
So just kind of working on this. It was kind of difficult to explain, I'm not quite sure. I wasn't really able to do it very well because of all the tightness were here and here, so. I mean, we did a little, he just wasn't able to like literally move it.
Yeah.
It was hard to hear and explain, like he wasn't able to do it.
So then it was maybe not the best choice. If it's complicated, they can't really do it, and they're not getting symptom reduction or anything. But it was a nice try. It gave you information that he doesn't have a lot of control. I mean, you can just watch him move, and you can see he doesn't have a lot of transverse.
Tell him hip stuff, he would just move his whole torso. So I did pick up on a lot of information by just seeing, and like which leg, because one leg he was kind of able to do with, and the other one was not at all. So. Okay, so let's explore that a little bit more. So if you're in this move, so you were having him move in the frontal plane, hip elevation, so that hip height. But he was moving in the frontal plane. If you look at if you think regional interdependence, and you're thinking this movement, that's a straight plane, frontal plane movement, right? Okay. If this is too difficult, because it's not necessarily a natural movement, a way to facilitate that could be doing something in the transverse plane. So if you have him rotating, it's the similar muscle groups. So let's back up the truck. When you're doing this and standing, what muscle groups are you using? Go ahead and take a look there. The glute complex.
What's happening here?
Your power diamond.
The power diamond actually is not an active structure. It's a passive. The force goes through it. But what are the muscles underneath your hand? And everyone else can kick in too. Your QL, your lats. What is inside at in the vertebral column? The psoas runs along the anterior lumbar vertebrae and crosses the hip. So let's see. So what do we have? So yeah, explore that whole region. We're going up here, this area.
I was just trying to figure out how to work it. It wasn't really moving.
Oh yeah, I'm sweaty. So yeah, just point. So that's the lat. And then if you want to dissect, do that. Oopsie. Oh, God. Oh, hell.
So during these streams,
So now we look down here, and we see these muscles here, external obliques, transverse abdominis, the serratus posterior, all of those muscles, the paraspinals. So all of those, so when you're having when you're having somebody do this, and they can't do it, you could just approach from a different angle. If you know your anatomy, and you're thinking, I'm having him activate these muscles, it's easier if you're fully supported and moving that muscle on something else, rather than, so this is open chain, meaning this leg's not connected. A closed chain activity is easier. So thinking of, just so if you know your anatomy, you can flip the script a little.
So wait, wouldn't it be targeting the glute med of the side that's closed? Because that's the one that has to contract to, like, press and lift?
Well, you're doing, this is not, that movement, watch, this is not a single joint movement. This is not just the glute med. This is the glute med and everything else.
I was just thinking it more from, like, the pelvis perspective of this contracting to lift this side. But I guess both is happening.
This is targeting just the glute med because it's a single joint movement. Nothing else is moving. Just the pelvis is going up, is coming up and then down. Nothing else is moving. Look at here. Watch here.
I was thinking
Look at the contract. Well, just regardless. Look at the complexity of the movement pattern. Look at the rest of my body, regional interdependent. What all is moving? Just my pelvis, mostly. The most obvious movement right now is the pelvis only. You came in and he's doing this. Look at my whole body. This is a multi-joint exercise. So you can't be looking at just one muscle if you're moving a multitude of joints. And so that's where just being able to look at your anatomy and saying, in the open chain, because really this is not a glute med exercise. This is more of the side body movements. Yeah, the glute med is involved, but all the motion is coming through these muscles. These muscles in this activity are lifting your pelvis, not the glute med here. And so being aware of so I would put him, if you wanted to concentrate on that same muscle group, the same movement pattern, have it be closed chain and do rotation to start with. And you're getting those movements. So just,
sensitivity in his back.
This is actually going to flare up his back.
Okay.
Because you're creating a shit ton of rotational forces. You're closing, if you're only doing it on the side, if you're opening the side that is symptomatic, then you're okay. Because right now, you're closing all of the foramen on this side. So you're crushing whatever is in those. So the foramen are like this, and you're just closing them and shutting down all the spine, all the places where the nerves exit on this side. So you're shutting all this down and crushing everything. You're opening on this side if he gets this hip up high enough. Otherwise, this side is in neutral, and the muscles are getting tighter. So if somebody comes in and they're tight and they're symptomatic, creating more tightness isn't necessarily what they need. They need to have openness and muscle relaxation, which is why I keep talking about hip flexion with him. Bilateral hip flexion, you're opening up the foramen, you're stretching and relaxing those muscles that are tight all the time, because he walks around like this. These muscles are constantly tight, they're shortened, and that could be causing symptoms. So doing rotational activities and flexion activities opens this foramen. So you're opening the foramen on this side. If you're reaching up and long, you're not closing down so much on the convex side. or on the concave side. If you're down lower, if you're going this way, you're opening here, closing here. Does that make sense? And that's where that anatomy, understanding your anatomy and what it is that you're trying to, target is really important. And just looking at that person, how they're moving. And usually if they come in moving one way, you probably want to have them move differently while they're in here, because that's what they're paying for. Okay, so we did, what'd you got? What are you playing with?
Yeah, so when we do feature streams, we can queue up a few of these so that they're in sync with what you're
doing. Oh, yeah. Yeah, that's fantastic. Can you target the,
starts below the skeleton, so.
The torso muscles? Keep rotating. There you go. Nice.
Look at that.
Yeah, lats. And that's like last week when we were talking about how the lats advance the pelvis.
Yes.
And they're really a power muscle. In our runners, we used to really not pay any attention to them, but now they finally figured that out, so, which is good. Okay, so can we go back to the study? Because I think we have like 10 more exercises, but I think it won't take long to get through the rest of them.
3, 2, 1.
There you go. Okay, so scroll down to figure 5.
Let me throw it up on.
So this stuff is fun. So there was research years ago. I won't go off on that tangent. Okay, so now let's talk about making sure that people are doing, so the same thing with the side lying hip abduction. It's the same principles as the clamshells. It's technically one joint, but because the leg is all the way long, you have the weight of the entire leg as a lever arm, and so it's a lot more difficult of an exercise to do. So let's just make sure everyone's cueing people properly. It's the same cueing and the same mistakes or the same compensating people that people do as in the clamshells. So people want to be using the glute or the hip flexors instead of the glute medius. Do you want to? Okay, so Sydney, go ahead and walk through, just do this with Mike. So you be the client, or you be the trainer. So the same setup is you want to make sure their pelvis is perfectly vertical, that they're comfortable and supported. I'll usually cue them to put their hand here because then they feel supported, especially if they're going to push harder. You'd rather have them integrate, their serratus and all that. But anyhow, so the main deal that you need to make sure that you're doing is you'll see that the bottom leg is at a 45-degree angle. And that's because that provides support to the person. They don't feel like they're going to roll. They're not going to roll backwards, and they're less apt to bias the hip flexors. And so the same techniques, you've got your hand on the targeted muscle group, which is the glute medius. And so what you'll notice is your hand is on both sides of the joint. Mine is that my fingers are on like the greater trochanter, and the thumb is back on that. I'm along the insertion and origin of that muscle group. And then what's nice here is you can just peek forward and touch that the hip flexors without really taking your hand off. So you can kind of be aware, that's all hip flexor, nope, glute med. So we got our palpating our muscle group we're looking at. The bottom leg is supporting so that they feel safe. And then go ahead and straighten your top leg and practice the words that you use in your patient handling. If you hold on to the knee, reach from the front, there you go. And get up behind their pelvis, because now you're going to put the heel of your hand down, because you need about 10 degrees of hip extension in order to actually get the glute medius in this position. So that means the pelvis, you have to kind of rotate, because what will happen is, if you have them here and you lift their leg, they're going to rotate backwards like this. Yeah. And then when they lift their leg up, it's going to be hip flexor. So if you palpate first, hold them so they keep the pelvis so that it's vertical, and then say bring your leg back to right about here, and you want it to be about 5 or 10 degrees into extension. And don't put your thumb, what you'll notice is my web of my hand is underneath the kneecap, so don't ever put your hand directly on the kneecap, that's not very comfortable. But now you have control over the lower leg too. See how your fingers have control? So you can do like this? Yeah, but you're still there, you know. Okay. All right, so straighten your leg, bring it back towards me, and then you provide, so don't have your fingers on both sides of the joint. Bring the heel of your hand further back, medially. There you go. But keep your fingers so that they're in line with, like the horizontal, in line with the muscle fiber. So now we got him in about 10 degrees of extension, and have him put his hand on the floor in front of him, because I don't really like all this rotation here. Ideally, we have everything aligned. So, okay. Now go ahead and lift your leg towards the ceiling. There you go. It's this muscle group that I want you to use, and so you should feel that glute med kicking in, and then you teach them, okay, and then take your hand, finger, and you might just guide. And so now, that's the proper Jane Fonda. I don't know if you remember Jane Fonda. But really keeping it into that extension. And so the vast majority of people, I don't usually give this as an exercise because without cueing the patient and making sure that they know how to do it properly. So this is a really specific glute med only. The mistakes that everybody makes is they have it in hip flexion, and then they're just strengthening the glute, the hip flexors, and people are strong enough with that. Okay, so that was the hip abduction, side-lying hip abduction. So that's the concentric. It's still one joint, but it's increasing the lever arm and making it harder. Yeah. So we were shortened lever arm, lengthened the lever arm, fully lengthened lever arm. And it's all abduction. Do you see that progression? Yeah. The lever arm is something to take into account. Okay, so then the next one, now we go from single joint to multi-joint. Yay! We finally got there! Okay, so now we're going into plank. So get on into and so the same ideas are present with the plank. So everyone get into it. So honey, let's get you see your elbows. Don't hurt your elbow.
I played volleyball, I'm used to that.
It doesn't matter. Still want to be nice to you. All right, so everybody get into the proper plank position.
Side plank or?
Side plank. And so that would be, if you notice in this photo, the elbow is underneath the shoulder. And this is really important because I've known people who've injured their shoulder, especially women who don't have a lot of muscle. They've really injured their shoulders. So elbow is underneath the shoulders. Okay, everybody relax. I'll just show you. So elbow is under the shoulders, feet are together. You can balance yourself in the front. A lot of people won't do this. Cue them to do this so that they have proper form. Sometimes people, they get a little testosterone and they want to do it the hard way. Yeah, and it's just like, just stop. So let's just do this right. Okay, put your hand here for balance. Lie on your side. Probably more comfortable. You have more range that way. More, okay, on your side. And it's the same idea. You want to have a straight line here, and now go ahead and just lift your hips off the ground. And so the compensating movement would be bending at your hips and coming into hip flexion, and so it's your TFL. And so let's say somebody can't get their hips off the ground in this position because this is the hardest. Because why? Go ahead and come down. Why is this the hardest? The longest lever arm. So go ahead and have them bend their knees. And you know what you might do? Just to keep people's... You don't want to make people feel stupid or weak. Sometimes you do. Sometimes people need it. Some people might need to be taken down a notch. But that's okay because there's a lot of other ways to do it. But don't be a dick to your people. If you have them do an exercise in the easiest way first...
And then progress. I've learned that, yeah.
You're really doing everyone a favor because you're just not having people do something that's embarrassing, if they can't really do, and it's hard, you're really not increasing their motivation. It's not the best way. So the easiest way to have them do a side plank is go ahead and have your knees bent at 90. There you go. And you've probably already done like the abduction just so you can see what's happening, and that's why you're choosing to progress them to this. Now go ahead and just lift your hips and see how I'm palpating at the same place, because I'm also providing support. Lift your hips off the ground. There you go, that's great. And then come on down. And so you'll see on here, the next progression is to lift that top leg. You can do that here with the knees bent. Lift your hips. Now lift this top leg. The whole leg. In with the knees bent. So we're shortening the lever arm, making it easier. There you go, come on back down. So does that make sense?
Yeah.
And so now, flip over and see which one is harder. So you can have the dominant leg down towards the ground,
Or dominant leg down is easier.
or you can have, so the leg that's towards the bottom, towards the ground, and is going to be a way to progress it. So you can just flip somebody over and make it harder. Which one do you think was harder? If you, let's want to target the right glute med.
The one that's on the bottom.
So if you flip over and lift, which is harder for you?
Lifting the foot up farther.
From the top?
From the top.
Yep. So that can be a way to make it harder. So you can, if somebody is side lying, if they're doing, so here's kind of a thought process to be, so you progress to side lying, long lever arm, single joint, which is the glute med here, right? But it's the long lever arm. And you want to progress them to the next hardest, which is multi-joint, shorten the lever arm, and have them come up. And so now the lever arm is shorter, and this is technically an isometric contraction, right? Because the glute medius is, because the joint is not moving.
Yeah.
And now we added a concentric contraction with a shortened lever arm. And let's say you wanted to add a baby step between these guys and these guys. What would you do? You could just flip them over and make it harder with the shortened lever arm. Does that make sense?
Flip them over. Don't you have to do both sides anyway?
Depends on what your goal is. If they're significantly weaker on one side, you're going to be targeting that side.
Okay.
So you can make it harder by just flipping them. But just being aware that when they're on one side or the other, you're targeting the muscles differently.
So are you saying regardless of if your knees are down or if your knees are straight or bent, it's still targeting the glute that's on top? Or the glute that's on top? Because when I'm here, I feel like I'm squeezing more here. Well, I guess that might be more core. Oh, it is core. Okay, never mind.
It's the bottom glute that is the most active.
That's what I was thinking, but then when we were talking, I kept switching. Okay, same page.
Well, if you're moving your leg, that's a different conversation.
Yeah.
Because both glute medius are active, they're just active in a different way. So if you're abducting, that's a concentric contraction, and then the other one is isometric. Does that make sense? So just understanding this. So let's see, is there more? I can't remember if there's more, Chris. Because I want to show you, I don't think it's in here. Oh yeah, and so now we have the front plank with the hip extension. So let's go in, it's like I showed you before on all fours. So instead of doing the bridge, which basically does nothing, you get into your front plank and bend your knee at 90 degrees, and go into just extension. Nope, Keep your knee bent and dorsiflex your foot and put your heel towards the ceiling. There you go.
I tried, I just couldn't see what direction it was.
Yep. And what, no, but you keep everything. So what's interesting right now, do that again. Were you moving your hip at all? No. You were doing a push-up. And so we're trying to go into hip extension.
Yeah.
This is straight hip extension. And to somebody like you, this could be hurting. This could be. This could be something that janks up the low back. But this is proper. But what I did is I just corrected your form, Sydney, because before you were doing it this way.
I was going out?
Uh-huh. Because it's easier. Because why? Because
It's
the glute max does.
instead of diagonal, so it's farther
Because the
away.
glute max can come in and assist abduction and external rotation. So you were just naturally using the bigger muscle group.
And it's the hip flexor strengthening for the legs that's down too.
Absolutely. Yeah, so it's a multi-joint. So this is, I mean, this strengthens the entire body. And it's a lot more, and don't straighten your knee. Because you're trying to get your hamstrings. So you're assisting yourself by adding the hamstrings. When you straighten your knee, you're adding your hamstrings. When your knee is bent, your hamstring is passively insufficient. So this is just glute max. When you add this, you're adding hamstrings to help. So this is specifically glute max. And all the others. So this is technically concentric, glute max, multi-joint. Fun, right? And you're getting, this is not primarily glute med, like we've been talking about. And then, let's see, rotate, we'll scroll down, Chris, and let's see what we have next. I can't remember, I haven't looked through this. What's next? And then we've got some of the bridges, where they're adding the arms up.
So with the other conversation earlier with the bridges not being effective, so probably just jumping right into unilateral bridges would be.
Or just don't do bridges, do something else.
So why did you say that?
Because it's common. This research article was objectively measuring the muscle recruitment in the different commonly used exercises. So there's not that there's not a.
This isn't a progression.
No. Well, it is. What we've just been showing is the progression. But the graphs show the different. So they're looking at all of the most commonly used exercises for the glute complex, and the bridge is one of them. And so there's a time and a place for the bridge, but in all honesty, I think it belongs with somebody like myself who is just using it. I don't use bridges for very long. And it's mostly for symptom reduction if they're having something radicular symptoms or something of that nature. It's usually more of a motor pattern and I don't use them for very long. So I really think that in this setting, there's so many other things that you can do that are more effective, more specific, and there's less, and that people feel like they're actually getting something out of. So I think, so this is a way to do a bridge that's harder. And then let's see, roll through. Yeah, I just don't think, well, I also worry about the bridge because people crush because people don't pay attention to what people are doing with their neck. And you probably have noticed I'm a big proponent of the cervical spine, and so you're having people do bridges and they're just fucking up their neck because all you're looking at is your pelvis. And so there's just so many other ways to do things. So I would just
I've taught new staff or new trainers to do bridges in the past. I mean, it seems safe, but I would have clients come in where I'd have them do it, and their back would just be jacked up immediately.
Absolutely.
And I was like,
yeah.
And so that happened enough for me to just not want to do it with anybody.
Yeah.
So it's one of the things I leave to the end of the assessment if I can't get them to feel their glutes. And sometimes I can get people to feel their glutes a little bit more when I did it.
You can get them to feel their glutes a lot more in all fours and actually targeting the glutes, which is hip extension. And so there's better ways to do it. And I think just with and plus, the hip thruster or the bridge, like from a client perspective, like how many people are going to lay down on their floor and do bridges, unless they are having symptoms that significantly reduces. Like, it's just, I think from their perspective, it's just a lot less sexier than doing something hard that seems hard. Like you have them do like a lunge. If you really want to, if you're doing a lunge or doing a curtsy squat, or a curtsy lunge, like there's so many harder things that you can have somebody be doing that really makes them feel like they actually did something hard. Like, this is just weird. I don't know. I think so. This is just more now into they're showing the pictures of the exercises that they included in the study. So there is a time and a place where this particular exercise, like a bridge, or this is another one that if you look at the graph, it's not shown to be that effective. It's just shit that PTs have come up with to make themselves look fancy, or just attempts at targeting the muscle groups, because human nature is to make things more interesting. But and especially like in the strength and conditioning and personal training world, like you want to have that newer, shinier, because you're marketing and people want to do the thing that's the bells and whistles and the new shiny toy. They don't want to do just the planks, because those aren't sexy. But there's plenty of ways to take these specific exercises and use them in ways that are more functional. And so now we go down through, like, you're better off, like, I love this single leg squat here that's assisted, because you can progress, because a patient will do this in their home. So you can be having them start off, let's say they've got gluteal amnesia. And so what I love about this, you probably notice, I love one exercise that you can change subtly to make it be harder. Instead of teaching them a whole new exercise, and then for one, it's less complicated for your thinking, but also it's less complicated for that patient. So you can still do different things, but if you have the same framework, when the patient, you can do a variety of things the same with the patient without doing a completely different activity and you're not staying on the same thought process. So what I love about the squat progression is you have somebody sitting, they're going from sit to stand. So every time they go from sit to stand, like at home, they just sit and stand a few more times. And then, so this is bilateral, stable surface. We'll talk more about the squats next week. So the progression for squats, bilateral, stable, right? And then your bilateral, staggered. So this is just a basic squat progression. Bilateral, staggered, unilateral. And so you can do all that with just this. So now you just progressed from the squat from double leg to single leg. Yeah. But this is technically assisted, and that's where the TRX is super fantastic. And then the deadlift is something that's really powerful that I would like for people to use a lot more. And why, if you look at a deadlift, now that we've been talking about anatomy, proprioception, balance, and all that, and maybe all of you do a deadlift because it'll help you with your thinking. So everyone get into a deadlift position. Lift one foot off the floor. So this is where you have a slight bend in your knee, because you have more control. So now you come into your deadlift. Oh God, I don't have enough range. So, and then come on back up. So what did that just tell us? Look at me. So what is this doing for our bodies? This is how many joints?
All of them?
Multi-joints. How many planes of motion? Just one plane. Yeah, that's not a trick question. But what are we doing? Balance and proprioception, flexibility for the posterior chain, strength and control of the pelvis. So this can be a glute med, glute max activity, and it's super functional, and it feels sexy. It feels hard. It feels like you came in here and you did something difficult, and you can make this harder by by adding, and this is, if you want to lengthen somebody's hamstrings, doing an active activity is where you're going to get lengthening of the hamstrings rather than a passive. Yeah, and so this is where you kind of get into the meat and potatoes of things. Let's see. So scroll through if we forgot anything. There's more. Yeah. So this is another variation. So if you're bringing so let's just now think about what muscles we're probably using right now. If we're going from hip flexion to hip extension, well, if your knee's bent, your hamstring is at 90, so it's passively insufficient. So it is, the hamstrings are isometric, right? So this is what? We're hip flexion, hip extension. So that would be primarily what muscle group? Yeah, the glute max, because the glute max is hip extension. But it's the complex because you're single leg, and it's having to control the pelvis. So that's something to think about. Okay, and then scroll down. I just wanted to cover all these. Perfect. Oh, and the step-ups are nice. Stepping up onto a surface.
How it increases the load so drastically from 2 to 1.
Well, the step-ups, I mean, you can be doing a bunch of things with the step-up. If you're doing just a step-up, it's your whole glute complex. Because what are you doing when I'm going from, is my hip flexed or extended? So now what is my hip? So I'm actually going into hip extension. What muscle group is primarily responsible for hip extension? Yeah, there you go. And you're using quads and all that. So the step-ups are nice and functional. What else?
That wraps it up.
Is that all of them?
Oh, wait, there's more.
Oh, yeah. So we already did these guys. Oh, yeah, so we did the hip hike, which is this. And then, like what you were talking about earlier, was just that single leg, knee extension, flexion and extension. So single leg, it's basically a single leg squat, only you're being very specific. And then the skater, we don't really do skating here, but the skate ski or the skater is where you're pushing out diagonally this way. That's the skater. So skate skiing, and you're using the arm swing, and you're coming here and here and here. So that's in just the frontal plane. But if you want to multi-plane, you're going. And that's a nice dynamic activity to do for athletes, like where I've lived, where people they skate ski and they skate for their ice skate for their hobbies.
I do it with volleyball just for lateral control.
Yeah, but I think that's too easy. Why are you doing it just that way? It's better. You're better at adding that dynamic because it's more complicated.
It's usually more of the stopping your weight from still going that way and kind of holding strong. But here, holds rather than.
Yeah, but if you add a dynamic component, so in that one, that's a good thing to do. But if you want to elevate your thinking and actually have people do something that's a little bit more harder, if you add a different plane of movement.
Okay.
So when you're doing, there's a time and a place for this, but it's one plane.
Yeah.
And when you play volleyball, are you in one plane of movement the whole time? No. It's not a grid. So compare these two. So what you can do, this is really great because it's specific and you can do more repetitions because it's so specific to just those targeted muscles. But if you want to then replicate more of a functional movement pattern, you add this because when you're to see how different that is when you land. Feel how much more, so when you land, look at all this when you land, there's all this is happening.
Yeah.
Especially if you incline your torso forward, like so that you're pushing yourself off, and actually getting somewhere. So now it's a lot more, you're adding a lot more dynamics to it.
Yeah.
But if you use your arms, so skate skiing is, it's like hockey skating. So it's this. And so remember we talked like last week, talked about how the shoulders are connected to the hips. So training people to use their body, because you're also using your lats now. So if somebody wants to, you want them to get further in that direction, you're going to use your arms to get there, right?
Yep.
But see the difference between, so standing here on one leg, go ahead and watch, do it with me, and then leap as far as you can at a 45-degree angle and get in front of yourself. There you go. There. Okay. And now switch and come over here as far as you can. There you go. I love how you just brought your, feel how much you're doing here. This is so, and for women athletes, learning how to control your knee in the landing position is critical.
Yeah.
And so having one session where you train a female athlete how to keep the knee in the safe zone can significantly cut down on the incidence of an ACL injury, because it's actually, we created a program called Knee Bound when I was in Bend, Oregon. Their clinic was called Rebound, and we marketed it. It was a 20-minute, 3 times a week during the off season, and then during the season we were hoping they'd do it like once a week. But it really targeted all of the variables that contribute to knee injuries in female athletes. But that's one of the things to really be mindful of. You teach them how to land, and so just take your skater drills to another level. So why did I say you can get more repetitions here?
Because it's only one plane.
It's less complicated,
Yeah.
but it's more specific. So if it's more complicated, it's less specific.
Mm-hmm.
And so just think about that as to what your goal is. If your goal is to be a specific muscle group, keep it simple and add load or reps.
Yeah.
If your goal is to be more complicated, you add more variables.
Yeah.
So that's how you can make that activity harder and more functional.
Yeah.
Does that make sense?
Yeah. I just
Woo!
play around with it depending on what age group I'm working with, because 12-year-olds can't really, they're not really interested enough to try to focus on me explaining the.
But you don't have to explain it. You just say, do this. You don't have to explain it to 12-year-olds. Just have them do this. And this is actually a lot more fun if you have them do it as a race.
Mm-hmm.
And just, they don't need all the information.
Yeah, it's just they are coming up with their own ways. So unless I'm
And so that could be,
their own way.
right. And that might be fun to see.
Yeah.
Because you can find out where they're weak or strong. And so that can educate your eye and make you think about being a little more specific. Like they're coming up with their own ways and they're always doing this with their knee, then you want to have them do something more specific for the glute med. Even just standing on one leg and trying to keep their knee straight.
Yeah.
That could be something so that could just really educate you.
Yeah. I'm really good at identifying all these things, but it's what's the first step to next type thing. So.
Yeah.
But that's an experience where I'm